Hello, welcome back. In this second video lecture, we'll be talking more about the history of medicine and then transition into continuum of care, primary care, and other related topics. Again, as we talked about going back to Hippocrates, ancient medicine was characterized by the belief that religion was caused by supernatural events or causes. The gods didn't like us or one thing or another. Hippocrates was the one who changed that, making medicine more of a science and something entirely separate from religion. Also introduced the idea of medical ethics. Medieval medicine was basically earmarked by building hospitals to take care of the sick. And these were managed typically by religious orders, monks, nuns, what have you. In the Renaissance, there was more of an interest in art, science, and philosophy, and especially with science and philosophy, a focus on general health sciences. Now, of course, in modern medicine, we have all kinds of things. We have mRNA vaccines, we have robotics, we have all different types of things. And then we have the training of physicians, nurses, and other allied health. Again, we talked about von Leeuwenhoek, Pasteur, Koch, Lister. All these were revolutionary types of things. Alexander Fleming continued this with the discovery of penicillin, the germ-killing mold, and then World Health with vaccines, eventually eradicating smallpox from the earth, except for some labs. And then we see different things with acquired immune deficiency, otherwise known as AIDS, electron microscopes, so you'd see the HIV virus, and many, many other types of things. So here we have some more questions. So which act of 1946 provided funds to modernize hospital infrastructure in the US? Was it HIPAA? Was it the Hill-Burton Act? Was it TEFRA? Or the Ryan White Care Act? And then question 5, relating to the tax equity fiscal responsibility, the TEFRA, what did that introduce? Did it introduce HIPAA privacy, Medicare prospective payment, Medicaid, integrity? And then 6, which legislation in 2015 created the merit-based incentive payment system, which we now know as MIPS? Was it MACRA, the American Recovery Reinvestment Act, along with the HITECH Act, MMA, or the Deficit Reduction Act? Let's pause here for a little bit and answer these questions. And of course, it was the Hill-Burton Act that of 1946 that modernized hospital infrastructure. The Medicare prospective payment system was part of TEFRA, and then MACRA, which introduced MIPS. We see some other things that key dates here that are discussed in chapter 1, the Pennsylvania Hospital, the AMA being formed in 1847, the National Medical Association being created to represent physicians and health professionals of color, the Association of Hospital Superintendents, now known as the American Hospital Association, in 1898. 1965, a big year. Friends of mine know it for Medicare and Medicaid. Medicare being the health insurance program sponsored by the federal government for the elderly and certain types of disabilities, and Medicaid being the poor for the a type of health insurance for people that otherwise would not have any, that's jointly administered by the states and the federal government. The feds give the states money, the states implement it per their own local state policies. Joint Commission was key for giving the idea of deemed status. So if you don't have deemed status as a hospital, you can't take Medicare or Medicaid funding. So that is a big deal. TEFRA, as we talked about, established the first Medicare prospective payment, which still survives to this day in a form. We refer to it as MS-DRGs, or Medicare Severity DRGs. And of course, DRG stands for Diagnosis Related Groups. And what's significant about both MS-DRGs and its predecessor DRGs is it requires hospitals to be reimbursed at a predetermined rate according to a discharge diagnosis. In 1986, we see the Federal Healthcare Quality Improvement Act that establishes the National Practitioner Data Bank, so physicians can't hop from one hospital to another in different states. It includes information about medical licensing issues and also includes medical malpractice payments. In 2001, the letter CMS became known as the acronym for the Centers for Medicare and Medicaid Services. This replaced the old acronym of HCFA, which was the Healthcare Financing Administration. Essentially the same type of agency, just with a three-letter acronym, the Centers for Medicare and Medicaid Services. 2002, we saw peer review organizations being changed to quality improvement activities, quality improvement organizations, still doing the quality control and utilization review as we all knew it, dating back to 2002. Then the Medicare Prescription Improvement Modernization Act, the MMA, was implemented in 2003. 2005, we had the Deficit Reduction Act, creating the Medicaid Integrity Program, which essentially relates to fraud and abuse, which we'll talk more about later on in not only this course, but other courses to come. And the Patient Safety Quality Improvement Act of 2005, 2015, we had the Medicare Access and CHIP Reauthorization, or MACRA, that combines the Centers from Medicare and Medicaid Services, CMS in other words, that included physician quality reporting systems, the meaningful use of an EHR incentive program, and the value modifier program into a program entitled Merit-Based Incentive Payment System, or MIPS, which is still with us today. 2016, we had telehealth, which many of us are familiar with, telemedicine, right? Where basically patients are seen over video, very convenient for the patients, very useful during infectious disease outbreaks such as COVID. And then telesurgery, where surgery is actually being done by a surgeon operating a robot, which may or may not be in the same location. When we talk about the term continuum of care, we're talking about if you could visualize a line running from left to right. And on the left, you would have some sort of minimal service, say like a televisit or a medical outpatient, and then going all the way on the right to intensive care. Where the patient care falls on that line is a continuum of care. In other words, it's a whole range of programs and services. And this includes three level: primary, secondary, and tertiary. And per the Joint Commission, the continuum of care should match an individual's ongoing needs with the appropriate level and type of medical, psychological, health, or social care or service. Primary care is what we know as our family physician, our personal physician, sometimes referred to as the PCP. This is the first point of contact, and this is seen by somebody in family medicine, internal medicine, pediatrics, and other different types of providers. Important to remember that it may or may not include a physician. It could include a nurse practitioner, a physician assistant, or so on. Regardless, what makes someone a primary care provider is that they are providing first contact. This includes like preventive care, acute, urgent care, what have you. This is also done in an office setting and is continuous and comprehensive. And the primary care provider, whether they're a nurse practitioner, a PA, or physician, they coordinate the patient's care, including referrals to specialists, labs, diagnostic tests, imaging, and so on. And the types of services they manage are the preventative care, as you'd see in an annual physical, family planning, health education, immunization, treatment of illnesses and injuries, and others. Secondary care are provided by medical specialists or hospital staff members to a patient whose primary care was provided by a general practitioner who diagnosed and treated the patient, excuse me. The primary care provider refers the patient to a specialist. So somebody comes in, sees their primary care provider, shortness of breath, rapid heartbeat, maybe some chest pain, they might be referred to a cardiologist. That's an example of how the secondary care works. If the referral does not get made by the primary care provider, the patient's care may not be reimbursed by CMS or other payers. In fact, a lot of specialty care services only see patients who are referred to them. Now we have another quiz. Primary care is best described as what? Is it the point of first contact for general health services? Is it care provided by specialized hospitals? Is it experimental medicine, or is it cancer research only? Question 8, which of the following is an example of tertiary care? An annual physical exam, pediatric surgery in a teaching hospital, family planning or counseling, or routine immunizations? Then question 9, for-profit hospitals differ from not-for-profit hospitals because of what? They do not charge patients, they're government owned, they distribute excess income to shareholders, or they don't need to be licensed. Let's take a moment and answer questions 7 through 9. And here are the answers. Primary care is the point of first contact for general health services. Question 8, pediatric surgery in a teaching hospital. Answer to question 8. And with for-profit hospitals, they distribute excess income to shareholders. And thank you for watching this video lecture. Hope to see you online shortly. We'll be talking more about the idea of healthcare delivery in the United States in the upcoming video lectures. Have a good day.